So Dawn and I are excited to come and talk about what's happening with measurement. In less than an hour, we're going to cover the complete state of the science. So hopefully we'll take you on a quick ride. What we want to do first is take a step back a little bit and figure out what are the goals. What are we really trying to achieve here with shared decision making? Then we're going to talk about some of the issues around choosing measurable indicators. So if we know what the goal is, how do we actually choose something to measure that? What are some of the issues we need to think about? And then third is, given the state of the evidence, what are some of the key issues around measurement that we need to consider and think about if we're trying to move this field forward? So the place where I often start when I'm thinking about high quality care, and this I think reflects a lot of what you heard from Jean this morning, when we think and read about different definitions of quality of care, what we're trying to achieve with healthcare, there are themes that come up. And these come up whether you're looking at reports out of the Institute of Medicine or reports out of patient groups. And the themes reflect how important it is for patients to be fully informed, for patients to get treatments and tests that reflect the patient's wants, needs, and preferences, and that they play a key role in making healthcare decisions. So these three themes are really what's sort of focusing me in the work that I've been doing in trying to measure decision quality, and I think will hopefully focus us today. So shared decision making, before we go too far, what are we talking about? What is it? How do we think about shared decision making? And there are a lot of different definitions, and I'm sure folks in this room have different takes on this, but at the core, it's a process by which a healthcare choice is made between a patient and often family members and a team of healthcare professionals. It really is at the core of patient-centered care, these decisions about what to do, what tests to have, what treatments to have, and thinking about how to do this well. A process obviously can be a good process or a poor process, and it depends often on the inputs to this process. You could have a great set of communication skills, but if, for example, we don't have good evidence around some of the treatments that we might be offering or about the outcomes, you're probably not going to get potentially a great decision. So I think we need to think about how can we facilitate a really strong process. How do we get information that patients and providers need in ways that they can understand it, in ways that they can use it at the point of care? Different patient decision aids are one way to do this. Decision coaching is another way to do this. Skills training for clinicians is another way to do this. There's lots of means to achieve this shared decision making, and we're going to be talking a little bit about all those different ways of engaging patients and their family in order to make good decisions. We're going to focus a bit on patient decision aids, mainly because a lot of the measurement has been around studies of these tools, evaluating these tools. I'm assuming many people here in the audience are very familiar with patient decision aids, have developed patient decision aids. These are adjuncts to the consultation. They focus on information, providing facts about the options and the outcomes, often providing probabilities, the likelihood of those different outcomes. They also, I think, distinguish between just generic patient education materials by focusing on clarifying values. So trying to help patients understand what these experiences might be, how they might feel about those different potential futures that they might face, and then sometimes explicitly engaging in exercises that help patients understand and think about what matters most to them. And then often they have tools to help support patients in the decision-making process, whether it's guidance in the steps of making a good decision and or worksheets that could facilitate the discussion with providers around decisions. So I want to share a case that illustrates some of the realities of decision-making. So if we take this out of a nice, clean research setting and show some of the realities. And we heard a case this morning, but here's another one that was from Mass General. And this is a man, Mr. M. He was 71 years old, referred to our orthopedic department for worsening right hip pain. He had x-rays that confirmed severe osteoarthritis. The orthopedic surgeon's note after their visit was that I went over in some detail the different treatment options, and he very much wishes to proceed with a right total hip replacement. So he was scheduled for surgery. But the decision-making process wasn't quite done. He ended up going home. At Mass General, there's at least several months between the time where you book the surgery and when it actually happens. So he had several months. He was talking with friends and family who had had the joint replacement surgery to try and get some advice on how to prepare, what to expect. He returned to his internist a couple months later for a pre-op clearance. And during that discussion, the internist sort of noticed that he was having a lot of questions and maybe even having some concerns. And we had just started a program where our general medicine primary care physicians could order decision aids for their patients. And so the internist said, well, let me send you this video. Why don't you look at it, and then we can talk about this and see whether this still seems to be something that you might want to do. So he was sent a decision aid treatment options for hip osteoarthritis. So a few weeks later, Mr. M sent a letter to the surgeon and to his primary care doc. I'm writing to tell you at this time I will not be proceeding with my right hip replacement procedure. Therefore, please cancel my appointments for pre-admission testing and for surgery. About 6 months ago, I added daily biking to my exercise routine, and after 3 months found the nighttime hip pain was gone. So that was one of his key, not being able to sleep because of the hip pain. When I saw you in May, I wasn't sure if this important change to my lifestyle would hold, and it has so far. So based on the conference with my primary care physician and on viewing the DVD, I decided that waiting for surgery is the best decision for me. So we canceled the surgery. As a fledgling case for our new decision aid program, we were a little nervous as to how this would be received. What would the orthopedic surgeon think? What would the hospital think? Clearly we think this was a good decision at the end, but what if that primary care doc hadn't been kind of paying attention and hadn't remembered that we actually had these new programs? So we sort of viewed this as a near miss. But I think it gets you to some of the complexities of, when is a decision really made? How would we think about the quality of this process? How would we make sure that what we think was maybe a near miss doesn't happen again? So what we want to do is have you guys think about, what's the goal here? What are we really trying to achieve? When I first started doing shared decision-making work or decision sciences work as an engineering grad student, I started interviewing women with breast cancer and had just read Ralph Keeney's value-focused thinking. And one of the techniques they used was trying to figure out, well, what are people's goals and values? And so we would sit down and I would be talking with a woman and she would say, well, I would ask her, what's your goal? What do you want to achieve? And she would say, well, I want to survive. And then I would ask, well, why? Why is that important to you? And they would kind of look at you crazy. Why are you asking me this? And then, take a few minutes and say, okay, well, here are the things that make my life worth living. Here's why it's important to me to have this survival. So what I want you to do, because I think we're in this room, everyone would say shared decision-making is clearly an important thing to do. We should be doing this. And I want to ask you guys why. What's the goal? What are we trying to achieve with shared decision-making?
So I'm going to move on and talk about choosing measurable indicators. So now I've changed the concept of decision support to be more inclusive, but we need to think about what's the measurable element for which there's evidence and or consensus that it can be used to evaluate shared decision-making or patient decision aids. And we need to be thinking about these indicators need to be valid, reliable, sensitive to change, acceptable, and feasible. And in terms of approaches to choosing a measure, one is that we can look at what's the goal that's relevant to the stakeholders, and we've just talked about some of the different goals that different stakeholders have. But I'm going to lead you through a few other things that you might want to think about when it comes to selecting measures. So one of the next things to think about is what's the objective or characteristics of the intervention. And so we have some of the objectives are really to evaluate, does the intervention work, or what's the effectiveness of the decision support interventions, such as providing patients with decision aids or shared decision making. Another objective might be to evaluate the implementation of the decision support intervention, and then what are the outcomes that would be relevant to that. One of the frameworks proposed by Karen Sepucha and colleagues is to look at what's the purpose of the measurement. And so from a research perspective, it's really looking at how good is that decision support. And it often needs to be detailed measures, theory-based, very controlled circumstances. This is like the ideal of measurement, is how can we do this in a controlled setting like they do with the rats, around trying to look at what effect does that have. The reality is we're in the real world often doing these studies, but it's more the clinical trials and the studies looking at does it work. The next purpose of measurement is looking at how do we use that measurement in clinical practice when shared decision-making or decision aids are implemented in the settings. And this, we are really looking at actionable measures what's feasible, what's acceptable, and how does it work within the real-world setting of everyday clinical practice. And finally, another way to consider measure is to look at what's the accountability or performance measurement and comparisons across different centers. So are we as a center doing a good job, and what are we being accountable for? And this is really where we want to look at what are the thresholds for benchmarks that we need to be establishing to look at, is shared decision making occurring or not? What's the cost associated? Is this feasible on a grand scale? And looking at risk adjustment. So there's many different purposes for measurement, and we're going to be challenging you to think about different types of measurement, although I think we'll probably be coming back to a fair amount focused on the middle one around clinical practice. One of the frameworks that I'd like to refer to is the Medical Research Council in the UK's framework for evaluating complex interventions, because shared decision-making and decision aids are both complex interventions. It's not like a pill where you can look at, did they get their 10 milligrams a day every day for 3 months or whatever. It's much more complex than that. And one of the reasons why I like to show this framework is because one of the first pieces of the framework is to really look at what's the theory underlying that complex intervention. And so when it comes to shared decision-making or decision aids, there's many different theoretical frameworks. One of the ones that I use, coming from Ottawa, is the Ottawa Decision Support Framework. We're really looking at what are the decisional needs, how do we support the patients to overcome what their needs are to then achieve decision quality. So when it comes to measurement, if you're using this framework, it's looking at, did we address the patient's decisional needs, and did we achieve decision quality? Some of the more recent versions of this framework have pushed us to think about what about screening for implementation needs, did the patient take action, and then what's the impact going out a little bit further. Another framework that we might want to look at for considering evaluation is the International Patient Decision Aid Standards, and in particular the chapter on establishing effectiveness that's just being updated right now by Karen Sepucha and Richard Thompson are leading this update. And in this framework, there's two measures that map nicely onto Jean's presentation. One is around the decision quality outcome measure, which is defined as a match between the chosen option and the features that matter most to the informed patient. And the second is the process measures, looking at things like, did the patient know a decision was being made? Does the patient feel informed about their options? Do they understand the goals and that goals and preferences matter? Are they clear about what matters most? And was the patient actually involved in decision making? And I'm only going to show one other theory, because one of the areas that I work in is looking at implementation and the science of implementing evidence into practice. And so when we're looking at changing practice, we're looking at changing behaviors. So one of the frameworks that France Legare likes to work with, and I also have used as well, is the theory of planned behavior. And in this theoretical framework, the behavior, which is the goal, which is shared decision making, we have behavioral intention, which is those that intend to do it are more likely to do it. But what we really need to study is what are their attitudes, what are the subjective norms within that clinical setting, and what's their perceived behavioral control. And some of the work and perceived behavioral control can actually lead directly to influencing the behavior, not just mediated through intention. And some of the work that we've been doing in the interprofessional shared decision-making research studies that we've been conducting is that these perceived behavioral control is very different depending on which profession you're working with. And so we can't just assume that there's a set of attitudes, subjective norms, and perceived behavioral controls that are the same for everybody. We need to really look at what's happening in that setting and what's happening across the different professional groups. So the next big challenge is you need to be able to measure it. So how do we find a measurement instrument? And so I'm going to talk a little bit about what is being measured and what are some examples of instruments. So Annette's already talked to you about the decisional conflict scale or the SURE test that screens for decisional needs. But there's lots of others that are being used. So if we look to the Cochrane review of patient decision aids and look at what outcomes are being measured, the outcome around decision quality, so the way we report on this in decision aid trials is looking at knowledge scores, realistic expectations or their understanding of the probabilities or chances of things happening. And the third outcome that is under decision quality is the match between values and choice. But interestingly, in 86 trials in our last update, no one has developed a composite measure of decision quality. And so we don't have any trials that actually report on, like, they call it decision quality and they report it in different ways, but there's actually no publication in the update, which was to the end of 2009, because we're updating again now. Decisional conflict is probably the #1 measure next to knowledge in terms of what's most commonly measured in these trials. Some trials measure whether or not the person who was undecided was helped to decide, and hopefully at a minimum that's what we're doing. We also look at whether or not there's a change in passive decision making, so the patient becomes more active. Specifically, when you look at the measurement instrument, we often talk about passive, which means paternalistic, doctor makes a decision, shared in the middle, and then the individual or the patient controlled decision making. In this review, we've grouped shared and patient decision making as one group to move and look at the shift away from paternalistic decision making. So when you're looking at comparing across studies, it's important to look at how we group some of these measures. Chosen option is another one that many studies, or pretty much all studies, report on. So whether or not they chose surgery or screening or medication, and whether or not there's a shift in this outcome really depends on what's the base measure, and is the base measure really high and then it comes down, or is the base measure really low and it comes up, or is it somewhere in the middle and it might not show much of a change. And then there's a number of other outcomes that are also measured, and one of the ones that's most challenging is around health outcomes, because overall we don't usually see a difference in groups between health outcomes. And that's because when they report on health outcomes, they don't measure and report on the health outcomes that were important to the patient. And so they just measure globally on what were the health outcomes. And when you've got someone with prostate cancer that's either going to have surgery or radiation, they're going to have bad health outcomes both ways, potentially depending on what they choose, and one isn't necessarily going to result in a better health outcome than the other than from a patient symptomatic perspective. So we need to really look at how do we measure health outcomes linked to what's important to the patient. There's no difference in anxiety, and Hilary Becker wrote a paper with us and saying, you know, we should just stop measuring anxiety, and I'd encourage everyone to stop measuring it. Look at what's a more sensitive outcome in terms of looking at that piece of the puzzle. Satisfaction, costs, adherence, there's a number of other outcomes. The work in a book called Implementing Change in Practice, led by Richard Grohl in the Netherlands, they talk about process indicators. So another set of indicators we need to be thinking about is what's the intervention? What's the intervention patients are being exposed to? Because even though we call it a decision aid, decision aids have many different elements depending on what decision aid is being used. Another one is reporting actual exposure to the intervention. I think often of a study that Dominic Frosch did using decision aids on the internet versus videos in the practice. And what they found is that very few men reviewed the decision aid on the internet prior to the consultation. But if they were given the decision aid to sit down and see in the practice, they're more likely to see it. And so we need to be thinking about were they exposed to the intervention. And then we need to describe the experience of those exposed to the intervention. And it gets back to, Eugene talked about it in his talk this morning, is how do we measure and look at patient experience? So the other area of measurement that I want to refer to is the work around systematic reviews of interventions to enhance shared decision making. And this is a work that's being led by France Legare, and one of the Cochrane review that we've done looks at third-party measures of shared decision-making. And in it there were 5 studies, and some of the outcomes or instruments that are being used and outcomes in this review is the option instrument, the decision support analysis instrument, the physician informative and participatory style, patient active, MD-patient interaction, and physician behaviors facilitating patient involvement. So these are some of the types of measures that are being used, but more particularly the option and the DSAT are really more third-party observers. Is it happening? We also looked at 21 studies where the patient reported their role in shared decision-making. So in this study, we've gone to that center. We don't want to know that the patient made it alone or the practitioner made it alone. We specifically want to look at that shared. And in both of these studies, what we concluded is that if we just give a decision aid to a patient, it's usually inadequate. We need to activate both the patient and the provider if we want to actually influence shared decision making. And a really exciting paper that's in press and coming out, and again led by France, she should probably be here to present this data, is the title of this is Some, but not all dyadic measures of shared decision making have satisfactory psychometric properties. And so in this study, if you look at the first column, what we did is we took the work of Marla Clayman and McCool and Clayman, and looked at what are the essential elements of shared decision making. So defining the problem, presenting the options, discussing pros and cons. And we looked to find out what instruments or items from instruments map onto the elements of shared decision making to try and get a measure of did shared decision making occur. And then what we did is we looked at, do we have an instrument that the patient can complete and the practitioner complete about what happened in the consult to look at a dyadic measure of what was happening. Because one of the challenges with third party is that it's very labor intensive. You have to tape or audio tape or video the interactions, and then the analysis is quite complex. And so we want to look at, is there a simpler way to look at what's happening in that room between the patient and the healthcare professional. And so in this study that's coming out in Journal of Clinical Epidemiology, you can see which measures were used that mapped onto the different constructs of shared decision making and how many items. And I put little stars in the end column when we looked at which ones had good psychometric properties, and this paper's coming out soon. And finally, we need to look at what are the measures that are being used to inform practice. And Annette already showed you a snapshot of this. But in this, more specifically, we're looking at the SURE items are actually being used to inform clinical practice in the project on implementation in Saskatchewan and another project implementing decision aids and shared decision making in Ottawa. So there are 4 items of the SURE scale are here. We also have the knowledge test items on a briefer version of the knowledge test, not the full version that we use for testing the decision aid, but a much simpler version that's really aimed around the key knowledge questions related to patients considering surgery for OA. And then the characteristics of the patient's values are also being reported in ways that can guide and inform clinical practice decisions, not just research in this area. And then another set of measures that we need to be thinking about is what are the accountability measures and performance measures that should be happening. And so some examples are there could be a defect rate, which is defined as the % of patients who do not receive the decision aid before hip or knee replacement surgery. Or there could be a hard stop type measure, which is the provider is not allowed to book the OR unless documented clinical appropriateness and use of decision aids. And one of the other measures that we're using in Ottawa is funding. The surgeons don't get funded for doing their joint replacement unless they refer through the orthopedic intake clinic in Ottawa. And if they go through the orthopedic intake clinic, they get a decision aid as part of the process of care. And so we're really looking at how do you actually get some measures at a systems level to enhance accountability for what's happening.
So the last piece, we wanted to wrap up by talking a little bit about some of the measurement issues to consider. And the first is, finding quality instruments, and quality in quotes there, because here we're talking really about the psychometric quality. So is this survey instrument measuring what we think it's measuring? And there are, lots of well-written work in survey research, in patient-reported outcomes measurement, criteria for evaluating the quality of measures. And we've talked about some earlier. Annette actually presented a bunch of the data on the SURE scale and on the decisional conflict scale, but thinking about appropriateness, reliability, validity, responsiveness, precision. And then thinking about the clinical sensibility. So does this make sense in practice? Is it interpretable? Can people look at this and make sense of it in a busy confines of a busy visit, or do we need to actually have large statistical models running in the background in order to understand and interpret the data? Is it acceptable? Is it feasible, et cetera? So really thinking about the quality of the instruments that we're using as we're moving to these next steps out of the research world into clinical practice. There's been a bunch of work done to try and evaluate some of the common instruments that have been used to evaluate decision aids. Jen Karuchko and Don and others had done a review a couple years back. So I think this was the 2003 Cochrane review. So there's 35 randomized controlled trials. They identified that the studies had 35 primary outcome measures defined. So there clearly wasn't consensus on what we should be measuring. And then they tried to go and look at, well, what's the quality of the survey instruments that were being used? And here's just a report on 8 that they sort of dug into more deeply. And 2 scales really met a large number of these, the decisional conflict scale and the control preferences scale. The appropriateness was defined as meeting any of the IPDAS criteria, either for decision quality or for the decision-making process. So you can see about half of them in these primary outcome measures actually were capturing something that, at least as the field has sort of said, these are sort of the key things we need to do. So I think there's still some more work to be figuring out what kind of surveys we should be using, what's the quality of these surveys. Just wanted to let you guys know there's a great resource that Don and the group up at Ottawa have in terms of a place to go where you can look at different measures. They have the publicly available measures ready to download. So I just wanted to put this up there, and these slides will be available. So if you don't know the Ottawa website already, a great resource for looking at evaluation. Second issue is interpretability, and I think one of the challenges as we move out of the research world, where you often have a research coordinator who can sit down and even incentives for patients to fill out 20 minutes of questionnaires. People want one question. Is there one question or 2 questions we can use to figure out whether this is happening? And so one of the questions that often gets asked, it's sort of an adaptation of the control preferences scale. Who made the decision about treatment of your breast cancer, knee osteoarthritis? And this is trying to get at, well, was it a shared decision? So if that's what we're going, why can't we just ask this one question and then we'll be done with it? When we do some interviews, we've looked at this, and we did some interviews, and we had patients then say, well, tell me a little bit about, what happened, what was the process like? So here's one woman who is talking about the experience she had. They didn't say to me, well, we could remove the breast, we could do this, we could do that. They just said, this is what we're going to do. And that was it. I wasn't in on the decision. So here was a woman who had a lumpectomy. She was never given the option to have a mastectomy. And so she wasn't in on the decision. Seems like mainly the doctor really made that decision. We talked to other women who, this is getting cut off. Other women who had different experiences. I made the decision. I'm very happy with the lumpectomy because that's what I wanted to do from the beginning. They, meaning my doctors, didn't disagree. They didn't agree, they just said okay, they understood. So clearly someone came in with a strong preference, the doctors accommodated that preference, it made sense, but mainly the patient made this decision. So a third woman, talking about she, meaning the doctor, was compassionate, gave me the data I needed. We talked about statistics, sizes, measurements, things that helped me things that helped me with my decision. So the first time we're really hearing about maybe more of an interaction, some information exchange. But the challenge is, so all 3 of them checked both equally on the survey. So getting one question and trying to interpret what that question means. If we just had that information, we would say everybody made a shared decision, we were doing great. But when you look at their experiences in those narratives, you really feel that something else is going on here. So the challenge, I think, sometimes is obviously, if you haven't had, how do we interpret these things, and how do we get questions that patients can actually answer? If you haven't had a shared process, it's very hard to interpret the question. And this, I think, also goes back to something that Annette touched on, which we found often, is that when you ask patients how informed they feel, they might say, I feel very informed, and then when you ask them a couple of knowledge questions, they can't answer them. So you don't know what you don't know sometimes, and that makes it very difficult to try and figure out, can we get down to the 1 or 2 questions that will help us understand if shared decision making is happening. I think another issue is thinking about response burden. Really the goal would be to figure out, is there a minimum set of items that can be defined and used? Obviously the challenge is getting too short, or getting items that aren't interpreted the way we hope they are is a challenge. So developing and choosing measures that, for example, are we going to have a new measure for each specific decision? Can we have one that's generic across conditions and topics, like the SURE scale? And then thinking about, how do we have this debate between measures that inform practice versus measures for research. I think another issue that we're going to be facing with, if this really does start to become part of clinical care, part of practice, if physicians are going to start to get measured on this, we did a little bit of a study to ask physicians, actually, well, how would you feel about this? So how are they willing to be measured on their ability to inform their patients and this value concordance, matching patients' goals to the treatments. So we asked physicians, how do you feel about using patients' knowledge as a quality indicator? And only about half were very or generally positive. And it varied widely depending on the actual situation, the decision situation we had asked about. We also asked them, how do you feel about using value concordance as a quality indicator? And define that as, having treatments that meet your patient's goals. More doctors felt very or generally positive about that, which is interesting. But I think what we went on further to ask them was how well informed did they feel their patients were, and they actually indicated pretty big knowledge gaps. They didn't think that their patients were actually all that informed. So I think they realized that they weren't doing such a good job on the patient's knowledge, but they thought their patients were pretty happy, and they actually felt pretty confident in their ability to elicit patients' goals and concerns. But I think we're going to be coming into, thinking about, rolling this out, we're going to need to anticipate and figure out how to address maybe some of the pushback we'll get from clinicians on this. So measuring experience, I think it's come up often in the discussions today, the importance of measuring patient experience. We haven't gotten into details, but we'll hear tomorrow from Susan Edgman-Levitin about the CAPS work, which is the patient experience survey that's used in the US, so we'll have a little more I think, data to work with, but it's a difficult concept and construct. There's a lot of pieces that go into an experience of care. 6 months of a process with I don't remember how many, 18 different microsystems that Amy went through. How would you measure that experience for care? And I think one of the things that people are thinking about is there a need for qualitative measures? Is there some way to have some of the narrative help us understand what these experiences are? And here's just another qualitative account from a patient describing the decision-making process. So the most important thing for me was to feel informed. Neither the surgeon nor the oncologist told me what to do, but each of them gave me facts. And after a lot of talking back and forth and objective considerations, one or both of them said to me, well, what do you really want to do? So if we contrast this to some of the other descriptions of the decision-making process, you really feel that something important happened here and that you could really say that this was sort of more of a shared decision-making experience. And then decision quality. We've got a limited but growing evidence base for this. This is something I've been working on for several years now. And if we had another conference, I'd probably talk more about that. But you'll be hearing about people using some of these decision quality instruments, the knowledge, the goals, the concordance piece in the different projects. As Dawn had mentioned, there's actually, no one has used a composite measure of decision quality as an outcome for a study of decision aids. And so I think we need to understand a little better about how to use this measure, what it means. And then just to wrap up, I think, at least from our perspective, and there's some consensus around this from the International Patient Decision Aid Standards Group, when we're thinking about measuring success in terms of the quality of decisions, the outcome measure of decision quality, which is defined as patients who are well-informed and receive treatments that reflect and match their goals and concerns. Clearly also important to have process measures to figure out what was happening in that decision-making process. Decisional conflict, the SURE scale, measures of patient experience are going to be very important there too. I think there's a considerable evidence base on these measures in the research setting. There's much less in the clinical setting, and even less for accountability. So I think there's some great need for developing an evidence base there. And I think as we saw, the best outcomes and the best indicators will likely depend on the perspective that you're taking and the purpose for the study. So we hope to engage you guys in thinking about this from different perspectives throughout the next day and a half.